Hello and welcome to another Facebook Live with Isom. I am a board certified plastic and reconstructive surgeon located in Logan, Utah. And today I'd like to talk with you about a common problem that I see in my clinic and about an operation that we do every week in the operating room, and that is carpal tunnel syndrome repairs. So first of all, what is carpal tunnel syndrome? I think most patients and most people out there have heard about carpal tunnel syndrome. What carpal tunnel syndrome is a compressive neuropathy, basically pressure on the nerve. So the carpal tunnel is right here in your hand, right across the base of the palm. And the classic sign or symptom of carpal tunnel syndrome is numbness. Usually it's numbness in your thumb, index finger, middle finger, and usually half or this side of the ring finger. Carpal tunnel symptoms usually begin with numbness at night. You'll wake up at night, this thumb side of your hand is numb and tingly, you gotta shake it out, and it gets better. Oftentimes symptoms will happen while keyboarding or while driving. Oftentimes symptoms happen while at work, especially if you use your hands a lot in construction or other trades. There are certainly other causes of numbness in the hands. If you have severe diabetes, neck injuries, problems with degenerative disease in the neck, those can also be factors that may be causing numbness in the hand. But absent those, carpal tunnel is really, really common. And if you're finding that you have symptoms and they're starting to bother you, what I usually recommend my patients do is start with conservative treatment. The simplest thing to do is at night while sleeping, put a wrist splint on. One of those simple neutral Velcro splints that you can pick up in the pharmacy or grocery store. Wear that at night just while sleeping. And if the symptoms go away and aren't bothersome at all, then you've probably taken care of the problem. But research shows that people with moderate to severe carpal tunnel syndrome may be improved a bit with splinting at night, but it's not going to cure the problem. And usually a surgery is needed to fix the problem and to prevent further damage from occurring. So there's two basic ways to do a carpal tunnel release. Both methods basically treat the transverse carpal ligament, which goes right across your palm deep in the tissues. That forms the roof of the carpal tunnel. One way to do it is to make an incision in the skin right over the top of the roof, dissect down to the roof, and open the roof. The way that I prefer to do it is to make a small incision about 1 centimeter right in the wrist crease and go in with an endoscope and go right into the carpal tunnel, and then we're looking up on the underside of the roof. A blade is deployed and that roof is opened. Both methods relieve pressure on the nerve equally well. Both methods are safe and both methods are practiced by hand surgeons across the country. I prefer the endoscopic approach simply because it hurts less postoperatively, it's a smaller scar, and the recovery or time back to work is shorter. So for those reasons, I prefer to do an endoscopic approach. Now, if I get into the carpal tunnel and I don't have a perfect view of the transverse carpal ligament and I can't get a perfect view, I don't cut. Because the risk of this operation, whether it's done endoscopically or open, is there is a chance of damaging the median nerve, and we don't want to do that. If the median nerve is damaged, then it requires another surgery to repair. So the best way to avoid that is to make sure any cut is done clearly, and any cut, the vision is great. So there is a chance with an endoscopic carpal tunnel release that I might need to convert to an open approach, and that's done to be completely safe doing the operation. Now, I don't want to scare people away from doing the surgery, because the problem is if you have moderate to severe carpal tunnel syndrome and you don't get it fixed and it goes on for many years, it can and usually does result in permanent nerve damage. It could be permanent numbness, weakness, and thinning of the muscles, and it can lead to loss of hand function. So for these reasons, the operation is a fast and relatively simple operation that can fix the problems. The most common thing I hear from my patients who undergo an endoscopic carpal tunnel release is they wish they would have done it sooner, especially if they have a carpal tunnel syndrome on two hands, on both hands, and one's more severe. If we do that side first, they can't wait to get the other side done because it feels so much better. Usual recovery is about 2 weeks. I recommend no heavy lifting, no strenuous activity for 2 weeks. After 2 weeks, you can go right back to doing what you did before. You will notice a decrease in grip strength initially, and that will slowly come back over time. Just to show you, I brought in a little hand model that shows a hand without skin. This is your superficial palmar fascia. When we remove that, and we remove the tendons and some little muscles in there, you can see that we've got the median nerve coming out, and we've got the transverse carpal ligament, this white tissue that's illustrated here. Just below that, I make a little incision in the wrist. We go right into the carpal tunnel and divide that transverse carpal ligament. I actually have a video from a recent endoscopic carpal tunnel release that I performed, and it's going to show you what it looks like from the inside doing an endoscopic carpal tunnel release. Now, this is a patient who's a colleague and a very healthy gentleman who works out a lot, very muscular, and so had a very thick transverse carpal ligament and a lot of pressure in there, had a lot of years of numbness, and was really interfering with his ability to function well. So we did an endoscopic carpal tunnel release. So our camera's gonna shift. I'm sorry, it's gonna be a little shaky for a second, but the camera's gonna rotate now, and we brought this up on a computer screen to show you what an endoscopic carpal tunnel release looks like from the inside. So in this particular case, I have already made the incision on the outside, and this is the scope that's going in. What you're seeing across the top, and sorry for that little bit of glare, but what you're seeing across the top, those transverse or horizontal fibers, that is the transverse carpal ligament. That kind of filmy stuff is synovium, and I'm sorry that it's a little bit jerky here, but a blade was just deployed and divided the distal or the farther half of that ligament. And again, I'm dividing a few little fibers there that we can see. Once the two cut edges can't be seen in the screen at the same time, then we know we've completely separated. So the distal half has been cut. Now you can see the more proximal edge is being cut, and we go all the way close to our incision, that 1 centimeter incision made in the wrist. And I'm just going back. Once it's divided, the fat pad in the wrist drops down and you can't see much, and the last little bit of ligament is then divided just with a little scissor right at the incision line. I'm going to go ahead and replay that and see if we can get that to play a little more smoothly. So here's our transverse carpal ligament. The scope and the special device is being inserted. We're all the way at the end of it now in the palm. And that's a little blade that's deployed, and now we're coming back across the ligament. That's a little bit of synovium you see, and then that's the ligament partially divided. We're going to do a little bit more again. This is a big guy. He's got a pretty thick ligament there. And that last half now, we see one side, we see the other side. They're completely separated. I see one more little band. I'm going to divide that. And so the half of it is done. I'm just moving the scope, that little bit of flimsy synovium to get it out of the way so we've got a clear view of that transverse carpal ligament. And then the closer end is cut and divided. And that's it. So the last little bit, again, I divide it with a scissor under direct vision. Good. So, this particular patient had this operation done on both sides, one after the other. It is possible to do two sides at once. I do have some patients, they just can't afford to take much time off of work, and want to do both hands at once, and we can do that with an endoscopic approach. Patients are really worried about, well, how am I going to take care of myself? How do I clean up after using the bathroom? You can still do that after an endoscopic carpal tunnel release, even if we do both hands. So if one hand is much worse than the other, we'll do that hand first. If the two hands are very equal and we can't take much time off, then it's possible to do both hands at the same time. Patient, again, recovery is about 2 weeks, and this is an operation I love doing because the results are very predictable. Patients are very happy, and it's a very easy to fix problem. The operation obviously needs to be done very carefully and very cautiously to avoid complications. But it's one that I love doing and that we do often. So if you're having problems with carpal tunnel syndrome, or you feel you might have carpal tunnel syndrome, you can talk to your primary care doctor, or we'd be happy to see you and help you evaluate it. If there's any questions or other factors that we think may be causing the numbness, then we may do a test prior to doing the surgery to make sure that right in the wrist is really where the compression is going on. So we're making sure that we're doing the right operation for the right problem. Again, thank you for taking time to educate yourself about carpal tunnel syndrome, and we'd be happy to help you if you have any questions or problems in our office. Thank you and have a great day.